there is slight difference in time, okay, for the signal to be returned back to the receiver, okay. The classical example is a ambulance. As it approaches towards us, the sound is very loud, but as it starts moving away, there is a dampening effect, and this difference is the frequency shift. And on a and when we plot on a graph, the vertical axis is the frequency shift, and the horizontal axis is the changes in the cardiac cycle. Now, factors affecting frequency shift, first is the phase. So the highest phase is during the systole, that is the fastest flow of blood. Lowest is during the end diastole, where we get a maintained steady flow, low flow, no flow, or we get a reversal of flow. Okay. Now moving on to angle of insonation. So entire frequency shift is seen when the beam is parallel to the blood vessel. As we see here, when the beam is perpendicular to the beam as well as the blood vessel, we will not see any flow. But the moment we change the angle, we are going to see flow. The third is the vascular bed. We either get a low resistance or a high resistance flow. Now we use color Doppler to look for whether the flow is present or not. For example, we want to see cord around the neck. When we want to check bilateral renal agenesis, when we want to look at single umbilical artery, then we check for the direction of flow. That is very important. Red is towards the transducer and blue is away from the transducer, provided we have not inverted the color box. Okay, so as we see here, red is towards the transducer, blue is away from the transducer. Now, it is very important in cases of VSD where we want to check the blood flow across the defect. Now, lastly, we want to check the velocity of flow. So, it's very important in cases of tricuspid regurgitation, aortic stenosis, pulmonary artery stenosis, and in cases of MCA, peak systolic velocity, especially when we want to diagnose fetal anemia. Now, Dopplers in first trimester, we use it to see the nuchal cord, to see the ductus venosus. We do the DV Doppler. We look for the four chambers of the heart. We look for the heart rate, tricuspid regurgitation, and the most important, uterine artery. Dopplers in the second trimester, where we check the uterine artery, umbilical artery, MCA, DV, as well as flows in the heart. Dopplers in the third trimester, where we document both the uterine arteries, umbilical artery, MCA, as well as the DV. Now, moving on to types of Doppler flow. First is the monophasic flow, where the flow is on just one side of the baseline, and that is generally seen in uterine artery or umbilical artery flow. Now, the second is the biphasic flow, where the flow starts on one side of the baseline and then crosses to the other side. That is seen in hepatic vein flow. And the triphasic flow is the flow that starts on one side of the baseline, then it will cross the baseline and come back on the first side. So that is known as the triphasic flow, and it is generally seen in iliac arteries. So how do we differentiate low resistance from high resistance flow? Low resistance flow has increased diastole, the PI is less, and the flow is persistent throughout the cardiac cycle. High resistance flow is a very sharp flow. There is decreased diastole and the PI will be more. Low resistance is a continuous flow and we hear this classical sound. Okay, this is classical of low resistance. Now moving on to high resistance, we see a blinking vessel and we hear this characteristic sound. Now PI versus RI. RI and S by D is no longer of any importance. Only PI is used in obstetric studies because PI does not reach infinity when there is absent or reversed end diastolic flow. Now, how do we optimize any scan image while doing Doppler studies, especially OBS? Now, as we know, the fetus is constantly moving. So, but we still need to get a proper spectral trace. So we need to make sure that the fetus is not breathing very heavily at the time of scan. The fetal hiccups can also give rise to bad waveforms, and we can ask the mom to hold her breath when we are trying to take a spectral trace. Now, moving on to zoom, we have to always choose the area of interest and then press the zoom button. What happens with that is zoom will increase the frame rate, and as the frame rate is more, the quality of the image will be much better. As we see over here, we have not zoomed the scan image, and now on zooming, we can see a much sharper four-chamber view. Now, moving on to frame rate and color box, the moment we switch on color, the frame rate is going to drop, and so the quality of the image is going to go down. Okay, so what do we do for that? We make a very narrow color box and we place only on the site of interest that we want to sample. So if we choose a narrow color box, then the frame rate is not going to get so much hampered. Now moving on to sample volume or gate, and we have to adjust that to cover the blood vessel. We can change the sample gate size depending on what blood vessel we want to take. For example, in DV, we use a very narrow sample gate, whereas in tricuspid valve, we use a larger sample gate size. Okay, as seen over here. Now, moving on to angle correction. This is very, very important when we want to do any Doppler study. The optimal angle should be parallel to the blood vessel. So it has to be 0 or maximum 20 degrees, because the more angle we take, the more error we are going to get. Okay. So it's very important that we adjust the angle properly. Now moving on to PRF, or also known as scale. So low PRF means low velocity flow. High PRF means high velocity flow. And aliasing will occur when the PRF will be low. So we have to adjust the PRF according to the organ that we want to check. Okay. So if we place a low PRF while seeing an artery, we are going to get aliasing. And if we choose a very high PRF to see a vein, we may not see flow in it. So we have to choose an optimum scale to work on. Okay. Now moving on to color gain, the amount of color exhibited on the screen. So basically it has to be optimum. If we choose a very low gain setting, then we may not be able to see adequate color. And if we choose a high gain setting, as seen over here, we are going to see bleeding of color or overflow of color. So optimum gain settings is mandatory. Now moving on to the baseline has to be adjusted such that we see the entire spectrum trace. Now, invert. Ideally, we should not invert the color box unless it is mandatory, and the red will be above the baseline, blue is away from the transducer. Okay. Now moving on to sweep speed. Sweep speed should generally be about 4 to 6 cardiac cycles, and we should not make it very less. We can increase the sweep speed as needed. Too many waveforms is not good. Very less waveforms is not good. 4 to 6 is adequate. The only case where we need to take too many waveforms is when we are looking for any ectopic beat, any atrial fibrillation or atrial flutter. Now moving on to wall motion filter, we need to check artifacts. What happens in wall motion filter is when we keep a very high wall motion filter, the low velocities are going to get the low velocities will not be seen. So basically we'll be able to see only high velocity flow. So suppose we get a monophasic flow as seen over here. The moment we switch the wall motion filter to optimum, we see that the diastolic flow is there. So it is mandatory to choose the wall motion filter adequately. If we make a very high wall motion filter, we will not be able to see the diastolic flow well. Now moving on to feto-placental circulation. As we know, oxygenated blood from the placenta goes through the umbilical vein into the anterior abdominal wall and it reaches the ductus venosus. From there, it goes to the inferior vena cava and the right atrium through the foramen ovale into the left atrium. So all the oxygenated blood has reached the left atrium over here, as we can see in this diagram. Now, from the left atrium, it goes to the left ventricle to the aorta, which will divert the most oxygenated blood to the head and the neck vessels, as well as the coronary arteries. From there, it will go to the internal iliac artery, then the umbilical artery, which will carry the deoxygenated blood back to the placenta. So here we have to see that oxygenated blood goes through the umbilical vein and the deoxygenated blood comes back through the umbilical artery into the placenta. When the placental resistance is more, abnormal pressures will increase the afterload and that will impair the right ventricular function. So what will happen is anything that will impair the right ventricular function will impair the fetal well-being. Now, how do we do the fetal Dopplers? So starting with fetal heart rate. Heart rate, we can see straight from 5 weeks onwards, and we have to always use M mode in the first trimester. We can also use a color M mode. Power Doppler and color Doppler is not to be used in the earlier trimester. In the first trimester, during the NT scan, heart rate is ideally seen at the level of valves. Heart rate above normal seen in trisomy 13 as well as Turner syndrome. Heart rate below normal is seen in trisomy 18 as well as triploidy. In the second and the third trimester, heart rate is stabilized around 120 to 160 beats per minute. And we have to also see the pattern of waveform that we get. We don't just blindly choose the heart rate and then start moving ahead. We have to look for any irregular or ectopic heartbeats. Now moving on to uterine arteries. In uterine artery, we have seen that PI is very important and PI is the only thing that should be taken into account for the uterine artery. Now, uterine artery is a branch of internal iliac artery, and we take uterine artery measurement at the cervico-isthmic junction because beyond that it starts dividing into arcuate radial as well as spiral arteries. So I've seen over here uterine artery and the iliac junction. That's where we are going to take the uterine arteries. Now, trophoblastic invasion occurs in two waves. In the first trimester, spiral artery starts invading in the decidua, whereas in the second trimester, spiral arteries start invading in the myometrium and the terminal radial arteries. Now, a normal waveform in the first trimester will have a high systole, low diastole, and a high PI. So, a PI till about 2.3 is normal in the first trimester. And early diastolic notch, if seen, is the spectral counterpart of incomplete trophoblastic invasion. As the pregnancy moves further ahead, we see decreasing PI and increasing diastolic, which is because of spiral artery remodeling, and diastolic notch now holds no importance. How do we see the uterine artery? We use a transabdominal technique. We are going to take a sagittal section. We see the cervical canal, and then we are going to move the probe laterally and switch on color till we see the paracervical vascular plexus, and we are going to take the uterine artery over here. Same thing we do on the opposite side, and we take an average of the uterine artery. Okay. Now, certain points to be kept in mind while sampling the uterine artery. The gate should be 2 millimeters. Angle of insonation should be less than 30 degrees. There should be 3 similar consecutive waveforms. Peak systolic velocity should be more than 60 centimeters per second. That is mandatory. And mean uterine PI has to be used always. Moving on to transvaginal, sometimes we may not be able to get a good abdominal uterine artery. So we can also see it using transvaginal scan. We have to do it in the same way. And here also the peak systolic velocity should be more than 60 centimeters per second. Now, indications of uterine artery Doppler, it is mandatory in each and every first trimester scan. Okay. Defective placentation is strongly associated with most cases of early onset and severe preeclampsia. Uterine artery in PI, if we see that the mean PI is more than the 95th centile, 48% of females will develop early preeclampsia, and approximately 40% of cases of early FGR can be diagnosed. In the second trimester, we sample the uterine artery at the crossover of the iliac vessels. Uterine artery PI in the second trimester is better for early onset preeclampsia. So then you'll ask, why do in the first trimester? We are doing it already in the second trimester. But if the PI for the first time is taken in the second trimester and it is high, then we lose the opportunity to add aspirin. Aspirin should be started from the first trimester itself. In the third trimester, currently there is no rule, and we follow the same protocol and we take the mean uterine PI when we want to see the uterine artery. Now moving on to DV. DV is a very important structure. It is a very narrow structure and it connects the intra-abdominal portion of the umbilical vein to the inferior vena cava. Okay. And it has a very important role because it shunts oxygenated blood to the fetal brain. It is trumpet shaped. It is less than 2 millimeter in size. And we can document it as aliasing when we switch on color. Now, how do we sample the DV? In the first trimester, we will take a sagittal section and we are going to switch on pulse Doppler. The sample size is going to be 0.5 to 1 millimeter and the angle of insonation will be less than 30 degrees and the sweep speed will be 2 to 3 centimeter per second. Okay. Now the waveform of DV, this is a classical M pattern where we get S wave, D wave, and the A wave. The A wave is very important because whenever there is reversal of A wave, that means there is some problem in the fetus. Now we have to identify the aliasing and the sample size is very important. We have to keep it very narrow because DV is a very small vessel. Otherwise, we will get contamination from the inferior vena cava, hepatic veins, or the umbilical vein, and we can also ask the patient to hold her breath. Now DV in the second trimester, it is done in the same way, either in the sagittal or in the oblique section. And here the DV PI is very important in cases of early onset FGR. Moving on to third trimester, again done in the same way, and DV PI will help in taking a call whether we need to deliver the baby or not. Moving on to tricuspid regurgitation. Tricuspid regurgitation is of importance in the first trimester. It is a marker of aneuploidy. And how do we see for tricuspid regurgitation? We'll take a 4-chamber view. We are going to zoom and we are going to switch on color, but we won't diagnose on color. We are going to take a spectral tray. We are going to take a pulse Doppler. We are going to keep the sample gate of 2 to 3 millimeter. This is very important because we need a large sample gate size and we're going to place it across the tricuspid valve. And this sweep speed will be 2 to 3 centimeters per second. And here angle erection has to be done. It is very important. because we are going to look at the velocity of the regurgitant flow. If the velocity is more than 60 centimeters per second, it is tricuspid regurgitation. Now moving on to umbilical artery. Umbilical artery is generally taken at 3 points: the placental end, fetal end, and the free loop of cord. Generally, the free loop of cord is preferred because it's easier. Okay. How do we sample the umbilical artery? We take a free loop of cord. We take sample gate of 2 millimeter. Angle of inclination is less than 30 degrees. And we take 3 to 4 continuous waveforms. Now, it is important to know that till 12 weeks, it is normal to get absent end diastolic flow. Between 12 to 14 weeks, the end diastolic flow starts developing. And beyond 14 weeks, end diastolic flow progresses. So, as the pregnancy advances, increased diastolic flow and decreased PI happens. So, umbilical artery sampling should not be done before 14 weeks. Now, abnormal umbilical artery waveforms, that is absent and reversed end diastolic flow, they start occurring only when about 70% of the placenta is already affected. So it cannot be used for screening of late onset FGR. It is only used for early onset FGR. Okay. As seen over here, the first image is a normal placenta. Then when less than 30% of the placenta is involved, the umbilical artery will still be normal or just about high resistance flow. When 60% placenta is involved, we get absent diastolic flow. And when 70% or more of the placenta is involved, we get a reversed end diastolic flow. Also, fetal movements and fetal breathing can affect the umbilical artery waveform. Sometimes we may get a transient absent end diastolic flow. In that case, we have to recheck till we are sure of the absent end diastolic flow. Now, this is a interesting case. What do we see here? We see a true knot of the umbilical cord. And how do we diagnose it? We are going to see a pre-diastolic notch in the umbilical artery. So it is generally seen in true knot of the umbilical cord. Now moving on to MCA. MCA is a very important blood vessel and it's very easy to scan, and the angle is generally 0 degrees, and the RI and the PI is fairly constant throughout the gestation, and transient absent diastolic flow is normal. Now, an abnormal MCA happens in a case of hypoxia. In that case, there is increased diastolic flow, there is reduced PI, and MCA is very sensitive to hypoxia than umbilical artery. So we are immediately going to see all these changes. And in a patient who is diagnosed with FGR showing hypoxic changes, if all of a sudden we see that now we can't see the brain sparing effect, or we see that there is reversal of MCA flow, it means that there is cerebral edema and it can lead to fetal death. So we have to be very careful. We can't be happy that now brain sparing effect is not there. Once it is there and you don't see, you have to be very careful. Now, factors affecting MCA are fetal heart rate, breathing, behavior and sleep, glucose, and head compression. This is very important. If we apply a lot of force while taking the MCA, we are going to get a false low resistance flow. So we have to make sure that we are not using a lot of compression while taking the MCA. So we take a axial section of the head, and we are going to switch on color to see the circle of Willis, and the proximal MCA is generally taken. We are going to switch on the pulse wave Doppler and then try and sample the proximal third of the MCA close to its origin of the internal carotid artery. And we have to always try and make sure that angle is less than 20 degrees while taking the peak systolic velocity of MCA. This is important to diagnose cases of fetal anemia. In cases of fetal anemia, the peak systolic velocity will be more than 1.5 moms. So, yeah. Now moving on to aortic isthmus. It is seen between the left subclavian artery and the ductus arteriosus. It represents a watershed area and it informs about fetal hemodynamic compromise. So how do we look for aortic isthmus? Again, there are two planes. In the longitudinal plane, we go just beyond the left subclavian artery and we take a sample over there. And in the three vessel view, we are going to place the spectrum just prior to the convergence of the aortic isthmus on the DSI. So generally, we get a forward flow and a high resistance flow. Whenever we see a reversal of diastolic flow in the aortic isthmus, it is not a good sign. It is a marker of neurodevelopmental delay, and generally that happens after the umbilical artery has shown a problem, MCA Doppler is not normal, and CPR has already shown reversal, and then we move on to aortic isthmus, which is showing reversed flow, and generally this is of use only in cases of early onset FGR. Now, role of Dopplers in growth abnormalities. Now, why do we need growth? Now, if we don't check the growth of the fetus properly, there is an increased risk of perinatal mortality, morbidity. It leads to adverse infant outcome and increased risk of hypertension, insulin resistance, diabetes, as well as coronary heart disease. Now, what is size and what is growth? Size is when we take a static uh, reading. That is, we say that the weight of the fetus today is based on BPD, HC, AC, FL, and it's so and so grams. But we don't know how much the fetus has grown since the last time. So growth is dynamic and it is generally taken over a period of time. So we need growth curves to plot a growth curve. So the approved terminology now is AGA, which is appropriate for gestational age, SGA, small for gestational age, LGA, that is large for gestational age, FGR, that is fetal growth restriction, then early onset FGR before 32 weeks, and late onset FGR after 32 weeks. Terms like asymmetrical FGR, symmetrical FGR, and IUGR are no longer used. Now, how do we differentiate between small for gestation and FGR? Provided that the pregnancy is singleton and we have done the dating scan properly. That means we have checked the dates, that there is no lag, and we have assigned a EDD. After that, we can't change the EDD. And if all that is done and we know that the growth is okay, then we are going to start, and we see that the weight of the baby is less than the 10 center. So a small for gestation baby is constitutionally small, okay? And a FGR baby has got failure to achieve growth potential. The Dopplers are going to be normal in small for gestational age, whereas in FGR, the Dopplers will not be normal, as we will be seeing in the further talk. Now, how do we look for these growth abnormalities? So we do Dopplers. So uteroplacental function is done by uterine artery Doppler or umbilical artery Doppler, and fetal function is done by MCA and the DV. Now, diagnostic Dopplers, which help us tell whether it's early onset FGR, late onset FGR, or SGA, they are the uterine artery Dopplers, umbilical artery Dopplers, and the MCA. Whereas the prognostic Dopplers, which helped us to time the delivery, they are the severe changes in umbilical artery, DV, as well as CPR. Now, uterine arteries, the role is to look for placental perfusion, and we take a mean PI. If the early trimester is showing a high mean PI, then we have to correlate with preeclampsia and Pape moms. The umbilical artery is a surrogate marker for placental vascular resistance, and it is deranged in early onset FGR. That means the placenta goes bad, and it is not good for diagnosis of late onset FGR. Not the criteria for delivering a baby, it is only used for diagnosing early onset FGR. Now, as we have talked till now, late onset FGR occurs after 32 weeks, and it occurs when placenta is less than 30% damaged. That means that umbilical artery will almost be normal. Whereas early onset FGR occurs when there is absent end diastolic flow or reversed end diastolic flow, which means that 60 to 70% of the placenta is already gone. We have to wait till 32 weeks in a case of absent end diastolic flow, and we have to deliver before 32 weeks in a case of reversed end diastolic flow. MCA is a marker of fetal hypoxia, and it is very sensitive in the late onset FGR. Now moving on to CP ratio. CP ratio means MCA PI divided by umbilical artery PI. CPI generally is more than 1.08. When it falls below 1.08, that means there is some severe problem with the fetal hypoxia. And in late onset FGR, CPR plays a very important role. It is extremely sensitive. However, there is no information about acidemia. Moving on to ductus venosus, it is critical before 32 weeks, and it helps to manage and time the delivery of early onset FGR. Whenever there is reversed flow, there is a high suspicion of acidosis and baby has to be delivered immediately. We also check for biophysical profile, which takes into account fetal breathing, fetal reactivity, tone of the baby, and the fetal movement along with LICA. However, Doppler changes are seen earlier and they are more sensitive. BPP cannot be used alone. So early onset FGR, umbilical artery is used to diagnose. DV helps to tell us when to deliver the baby. In a late onset FGR, MCA is used to diagnose. CPR is a more sensitive marker, and increased surveillance and time for delivery has to be closely taken into account. Early onset FGR is generally associated with low PAPE. It is associated with hypertensive disorders and abnormal spiral arteries. The placenta goes bad, so definitely we'll get bad uterines and bad umbilical artery. The criteria for early onset FGR is weight or abdominal circumference less than third centile at less than 32 weeks, or the umbilical artery shows absent end diastolic flow less than 32 weeks, or the AC or the weight is less than 10 centile, along with high resistance flow in the uterine artery and high resistance flow in the umbilical artery. The cascade is generally first the uterine artery and the umbilical artery will start getting affected. Then the MCA Doppler will start showing changes, and they will be seen generally for a few weeks before we get severe cardiovascular as well as metabolic deterioration in the form of aortic isthmus and DV showing changes. So when we start seeing uterine artery PI, we have to start thinking that something is going to be wrong. The moment the umbilical artery starts showing some changes, we have to keep a close follow-up. The moment umbilical artery starts showing absent or reversed end diastolic flow, we have to monitor every day, every 2 days as per the protocol. And once DV starts showing changes, we have to immediately deliver the baby. Now, how do we monitor early FGR? We are going to use a team of fetal medicine specialists, neonatologists. We are going to counsel the patient. We are going to do Dopplers every day, and we have a certain protocol which we are going to follow, which I will be talking of now. However, striking a balance is the key. If we tell the patient to deliver early, seeing the Doppler changes, there is a high risk of severe prematurity and long-term neonatal complications. And if we ask them for a late delivery, there is a risk of hypoxia and acidemia, and there is risk of stillbirth along with long-term neonatal complications. So it is very important to strike a balance. Now, in early onset FGR, if the suppose if we diagnose at 24 to 25 weeks with lot of Doppler changes, we are going to do a personalized management. At around 26 weeks, we will deliver the baby if the BPP is less than 4, if DV is showing A wave absent or there is reversal of A wave. After 32 weeks, we can deliver a baby of early onset FGR whenever there is reversed end diastolic flow. After 34 weeks, if it is showing absent end diastolic flow, and after 37 weeks, if there are no Doppler changes. So now this is the Grata-Cost classification. This is what we have been following. In stage 1 and 2, when the weight is less than the third centile, CPR is more than 95th centile, uterine artery is also showing high resistance. We are going to follow every week and we are going to try and stretch till 34 to 37 weeks. In stage 3 of early onset FGR, where we get absent end diastolic flow and MCA is less than the fifth centile, we are going to follow up twice a week and we are going to try and stretch the pregnancy to 32 to 34 weeks. In stage 4 of early onset FGR, when we get umbilical vein which shows pulsatile flow or DV which shows more than 95th centile at around 28 weeks, or we get absent to reversed end diastolic flow at around 30 weeks, that's when we will try to deliver the baby at 28 to 32 weeks. And in stage 5, we are going to we are going to follow up daily and try and stretch till 26 to 28 weeks. However, in stage 4 and stage 5, the chances of mortality and morbidity are extremely high. So in early placental failure, FGR is a cardinal feature where the fetus has got low metabolic demands, and so there is a long latency to death. Whereas in late placental failure, FGR is seen very rarely. There are high metabolic demands and there is a short latency to death. So what is late onset FGR? When we get a mild placental insufficiency. So the umbilical artery Doppler changes may or may not be there, but MCA vasodilatation and abnormal CPR is always seen, and the fetus has a very low tolerance to hypoxia. So we have to very closely monitor such cases. I mean, cases of late onset FGR, MCA plays a greater role than umbilical artery. The problem here is the fetus has a very low tolerance to hypoxia. Sometimes the growth may not even fall below the 10th centile, but the fetus cannot tolerate hypoxia. So now how do we solve this? We are going to plot growth curves and we are going to keep a very close watch. So how do we diagnose late onset FGR? When the weight is less than third centile after 32 weeks of gestation, or we get 2 out of these 4 things: weight less than 10 centile, weight or abdominal circumference dropping more than 2 quartiles, which means from 75th, it will go down to the 25th centile. CPR is less than 5th centile, and umbilical artery PI is more than ninety for monitoring, and we have to do a bi-weekly or a weekly umbilical artery Doppler to look for when to deliver the baby. Now, when do we deliver a case of late onset FGR? At any gestation, if the BPP is less than 4, or if we get absent or reversed umbilical artery and diastolic flow. At about 36 to 37 weeks, when umbilical PI is more than 95th centile and weight is less than third centile. And after 38 weeks, if the fetus is showing any feature of FGR or MCA is showing redistribution. However, at 38 weeks is the ideal time to deliver a fetus of late onset FGR. Now we saw that DV starts getting affected only in early onset FGR, because umbilical artery is almost always abnormal. So the heart needs to function more. So the DV becomes abnormal, and the management is generally around the heart. Whereas in a late onset FGR, it is a mild placental disease. The umbilical artery is normal, the heart is healthy, and so the DV is normal. And in late onset FGR, the management is mainly around the brain. Now, what is small for gestational age? Where the fetus is less than 10 centiles, structurally normal, and shows normal Doppler flows. And in these cases, if the uterine artery is showing abnormal flow, the chances are very high that it will cross over to FGR, and we follow small for gestational age fetuses every fortnightly. Now, when do we deliver small for gestational age fetuses? Generally between 38 to 39 weeks. So, I would like to summarize my talk saying we have to diagnose growth restriction, do a proper growth scan, then we have to do good Dopplers, we have to do surveillance, and we can use growth charts to see how much the fetus has grown over a period of time. Now, moving on to Dopplers, diagnostic Dopplers, which help to differentiate between early onset, late onset, and SGA. They are the uterine artery, umbilical artery, and the MCA. And the prognosticating markers, they generally help to trigger preterm delivery. What we need to do in practice is establish gestational age, identify high risk groups, do the uterine artery Dopplers for all. We have to identify early onset FGR and do a very strict follow up for these cases. We have to do a growth scan at 32 to 34 weeks with Doppler, mandatory for all. We have to do a proper biometry, and we have to plot the growth charts. We have to identify growth restriction and SGA. We have to differentiate between early onset as well as the late onset FGR. We have to use surveillance tools like Doppler, BPP, CTG, or kick count, and we have to make a balanced decision for timing and mode of delivery. Thank you. I would like to say special thanks to Dr. Rajesh Chaubal for suggesting me for this talk, Dr. Nitin Chaubal, and my dear friend Dr. Meetan Preet for helping me with the slides. Thank you very much for a very patient hearing. I hope it was helpful.
Yeah, thank you, Dr. Vyas, for that amazing session. It was well attended and everyone stayed back till now. There are a couple of questions